Welcome for everyone. This is an e-poster for the 2021 International Web-Based Neurosurgery Congress. My name is Sofia Tejada Angarita and I am a medical doctor in the Hospital Universitario Clínica San Rafael in Bogotá City. And today we are presenting a case report about trap for ventricle, a typical presentation of tuberculous meningitis. Tuberculosis is a public health disease that affects the world population. Meningeal tuberculosis is the clinical presentation with the highest morbidity and mortality. One of the most frequent complications of this pathology is communicating hydrocephalus. Up to 5% of these patients can develop obstructive hydrocephalus and trapped ventricles, which represents a significant challenge in its management. We present a 28-year-old man with no previous history of tuberculosis, with a 6-month history of constitutional symptoms, headache, and emesis. Neuroimaging showed no communicating hydrocephalus due to obstruction of the left foramen of Monro, which is marked with the yellow arrow. The patient underwent a left neuroendoscopic approach to the lateral ventricle. A paired lesion was seen on the choroid plexus. Afterward, the foramen of Monro was explored, and it was totally occluded. A foraminoplasty of the Monro was attempted, but it was not possible to complete. So, a fenestration of the septum pellucidum was done. A CSF PCR PRA of the HSP65 gene was performed, with a positive result for Mycobacterium tuberculosis complex, thus making the diagnosis of tuberculous meningitis, and antituberculous treatment was started. At 7 days post-op, the patient presented headache, emesis, and confusion. The MRI showed the sign of a trap for ventricle due to obstruction of the aqueduct of Silvio and the drainage foramen of Luschka and Magendie, in addition to hydrocephalus. An open velotelomedullaris approach was done. The cerebellar tonsils are retracted and the foramen of Magendie is opened. Afterward, the fourth ventricle is explored with the assistance of an endoscope. The floor of the ventricle is seen, the medial sulcus and median eminence are identified. Finally, the aqueductoplasty was performed using a Fogarty catheter, permeabilizing the trap for ventricle. Tubercular meningitis can cause a communicating hydrocephalus in more than 80 of the cases. However, the chronic arachnoiditis and scarring of the meninges can cause a trap for ventricle. There are different surgical alternatives to manage this pathology, as they are placing a shunt in the fourth ventricle, performing an endoscopic surgery, or opening the fourth ventricle to the subarachnoid space by an open surgery of the posterior fossa. As reported by Dr. Udayakumaran, the fenestration of a trap for ventricle by a craniotomy is a safe and effective surgical option, with a very good long-term outcome and low rate of morbidity. On the other hand, Dr. Imperato demonstrated that endoscopic aqueductoplasty seems to be the ideal treatment because it restores a more physiological CSF pathway. We perform and open the compression of the fourth ventricle into the subarachnoid space of the magnum cyster and an endoscope-assisted aqueductoplasty to avoid placing a shunt in the fourth ventricle, due to the associated high revision rate and morbidity reported in the literature. In this way, the objective of restoring and maintaining the patency of the natural entry and exit pathway of the fourth ventricle was achieved. In conclusion, hydrocephalus is a common complication of tuberculous meningitis. Identifying the cause and type of hydrocephalus in a timely manner improves the prognosis of patients. The use of endoscopic techniques in obstructive hydrocephalus pathologies and its use in case of trapped fourth ventricle due to tuberculous meningitis seems to be safe. Thank you.